Okay, now what we're going to do is have a discussion about the autonomic nervous system. And the first thing we need to do is distinguish the difference between the autonomic nervous system and the somatic nervous system. Our discussion of the spinal nerve was largely, and the rami and where the fibers are going, was largely talking about the somatic nervous system, although you'll see that there is some overlap. But we need to understand what the critical difference is between the somatic nervous system on the one hand and the autonomic nervous system on the other. Now, a lot of people think that the answer to that question is that the somatic nervous system is voluntary and the autonomic nervous system is involuntary. And that's not true. That's not true. The somatic nervous system has voluntary and involuntary components to it. Reflexes are involuntary by definition. Similarly, the autonomic nervous system, although largely involuntary, reflex-driven, there are certain autonomic functions that you can learn to control. So the distinction is not voluntary versus involuntary. The actual distinction is based on the kind of end organ that's being innervated. The kind of end organ that's being innervated. The somatic nervous system innervates skeletal muscle. The end organ innervated by the somatic nervous system is skeletal muscle. The end organ innervated by the autonomic nervous system is either smooth muscle or cardiac muscle or glands. Okay? That's the distinction. So somatics innervate, the motor fibers of the somatic nervous system innervate skeletal muscle. The motor fibers of the autonomic nervous system innervate either smooth muscle or cardiac muscle or glands. Now, there is an important difference in the way these nerve fibers innervate these end organs. When we talk about the somatic nervous system, a motor fiber of the somatic nervous system, what we can say is that there is going to be, this is from figure 314, excuse me, we can say that there will be a cell body. That cell body will be, as you see, in the central nervous system. The axon of that cell body will leave the central nervous system, go into the peripheral nervous system, and keep on going all the way to the end organ, all the way to the skeletal muscle cell, no matter how far away that skeletal muscle cell might be. It's one neuron that goes the entire distance. So if I'm talking about a somatic nerve that's innervating a muscle in my hand, a skeletal muscle in my hand, that means that that neuron, which starts in my spinal cord, has an axon that goes from my spinal cord all the way out to my hand. So that neuron has an axon that's about 3 feet long. It's a very long neuron. Okay, but it's one neuron that goes the entire way. In contrast, when we talk about the autonomic nervous system, we're talking about a system that has a 2-neuron pathway. So here we're looking at figure 316. And what we see is we have a neuron whose cell body is in the central nervous system. So that sounds the same as what we said about the somatic nervous system. The cell body is going to be in the central nervous system. That cell will have an axon that will leave the central nervous system. So that also sounds the same. But the critical difference here is that that axon will not go all the way to the end organ. That axon will go to a second neuron. And that second neuron has its cell body someplace in the peripheral nervous system. And so that first neuron synapses on that second neuron. And then that second neuron goes and innervates the end organ, that smooth muscle or that cardiac muscle or the gland. Now remember, we said that the word that we use for a group of cell bodies in the peripheral nervous system, we said that word is ganglion. So these cells, these cell bodies, of these second neurons that are in the peripheral nervous system, where they live, where they're found, is in ganglia. Okay? They're in ganglia. And therefore, we call that first neuron, we call it a preganglionic neuron, because it's going to the ganglion. And we call the second neuron the postganglionic neuron, because it's going from the ganglion to the target or end organ. Okay? So in this case, in contrast to what we said about the dorsal root ganglion, remember in the dorsal root ganglion we said that the cell bodies found there are sensory cell bodies? Well, in these autonomic ganglia, the cell bodies are motor cell bodies. When we talked about dorsal root ganglion, we said there were no synapses. And now we're talking about autonomic ganglia, where there are synapses, where the first neuron synapses on the second neuron. So as a generalization, we can say that in the autonomic nervous system, there's always a two-neuron pathway, where the first neuron starts in the central nervous system and synapses on a second neuron that's in the peripheral nervous system. The second neuron innervates the end organ. There's one exception to that. There's one exception to that, and that's the innervation of the adrenal medulla. The adrenal medulla. Now, the adrenal medulla is innervated by one neuron. It's a one-neuron pathway to the adrenal medulla. The logical question would be, why is that? Why should the adrenal medulla be different? And what we'll see is that if you want to understand why things are the way they are, you need to understand how they develop. And the critical point is this. The adrenal medulla cells, the chromaffin cells of the adrenal medulla, are derived from embryonic cells called neural crest cells that we talked about earlier. Okay? These second neurons, these postganglionic neurons of the autonomic nervous system, they are derived from the very same neural crest cells. So what's happening in the case of the adrenal medulla is you have some neural crest cells that, if they had continued to differentiate, would have differentiated into neurons, these neurons, postganglionic neurons. But along this pathway of differentiation, they don't quite finish differentiating into neurons. They stop in their development at a point in which they are chromaffin cells of the adrenal medulla. And therefore, since postganglionic neurons are innervated by preganglionic neurons, therefore chromaffin cells are innervated by preganglionic neurons, because in a developmental sense, they are themselves the postganglionic neurons. They just didn't quite finish differentiating to get there. Does that make sense? Good. Okay, so what we can say about all of the autonomic nervous system, with the one exception of the adrenal medulla innervation, is that there's a two-neuron pathway. The first neuron is in the central nervous system. The second neuron is in the peripheral nervous system. Now, we can take this autonomic nervous system and divide it into two subsets. One subset is called the sympathetic nervous system, and one subset is called the parasympathetic nervous system. And if we take a look at figure 317 and 319, and look at them together, 317 represents an overview of the sympathetic nervous system. 319 is an overview of the parasympathetic nervous system. We see an important difference between the two. Even though they are both parts of the autonomic nervous system, so they both have their first neurons in the central nervous system. That's what you see here. That's what you see here. They both have their second neurons in the peripheral nervous system. That's what you see here. That's what you see here. A critical difference is where in the central nervous system their preganglionic neurons are found. And in the case of the sympathetic nervous system, we see that they are found in the spinal cord, but only the part of the spinal cord between spinal cord segment T1 and L2. So from T1 to L2 of the spinal cord, we will find preganglionic sympathetic cell bodies in the gray matter of the spinal cord, the intermediolateral column of the gray matter. But there won't be any parasympathetic cell bodies there. if we look at the parasympathetic nervous system and where those preganglionic cell bodies are found in the central nervous system, first thing you notice is that in that part of the spinal cord, the thoracolumbar part of the cord, we don't find any, but instead we find them at higher levels and at lower levels. The higher levels are so high that they're not in the spinal cord, they're actually in the brainstem. And we see that we have preganglionic neurons in the brainstem associated with cranial nerves 3, 7, 9, and 10. And then, if we go down the spinal cord to the lower part of the spinal cord, we see that we have preganglionic parasympathetic cell bodies in the spinal cord at sacral levels, at sacral S2, at levels S2, S3, and S4. Okay, so that's a significant difference. Where in the central nervous system the preganglionic is found. Okay, sympathetics at thoraco and upper lumbar levels, parasympathetics at cranial and sacral levels. Now, there's another difference that we can generalize. It's not always true, but what we will see is very frequently, in the case of the sympathetic nervous system, we will have fairly short preganglionic axons and fairly long postganglionic axons. Whereas in the case of the parasympathetic, we'll frequently find very long preganglionic axons and quite short postganglionic axons. And that's based on the issue of where the postganglionic cell body lives. In the case of the parasympathetics, in the case of the parasympathetic system, most of the postganglionic neurons, not all, but most of the postganglionic neurons are found in what are called terminal ganglia. You see that labeled here, terminal ganglia, meaning ganglia that are all the terminus, meaning end, all the way at the end. They are actually found in the wall of the organ that's being innervated, or on the wall of the organ. So these postganglionics are actually found in the wall of the gut, or on the wall of the heart, or right on the wall of the lung. That's how close to the end organ they're found, right in or on the wall of the end organ, of the organ in which the end organ is found. In the case of the sympathetics, that's not true. The postganglionic neuron is found a long distance away from the end organ, a long distance away from the end organ, so that the postganglionic axon has to travel a fair distance to get to the end organ, so they have fairly long postganglionics. Okay, what we need to do now is focus our attention on just the sympathetics, and then we'll come back and focus our attention on the parasympathetics. So let's take a look at the sympathetic nervous system. The first thing we need to pay attention to is the fact that sympathetics arise only from T1 to L2 of the spinal cord. However, sympathetics have to get all over the body. Sympathetics travel everywhere. All parts of the body receive sympathetic innervation. So that presents us with a problem that we have to solve. How do we get sympathetics that are arising from a fairly restricted part of the body and get them to distribute all over the body? Okay? So let's start off with the easy part. To get sympathetics to get to the part of the body that's innervated by T1 to L2, in other words, the trunk, basically, from about here to here. Okay? What do we have to do to get sympathetics to that part of the body? Well, that's the easy part. If we take a look at figure 318, we see an example of how that's happening. This would be a cross-section somewhere through the spinal cord and spinal nerves, somewhere between T1 and L2. Okay? And what we see is that the preganglionic neuron is in the gray matter of the spinal cord. Its axon leaves the central nervous system, and since it's a motor fiber, it leaves through the ventral root. We see that it goes into the spinal nerve, but then we see it leaves the spinal nerve in order to get into this structure, which is called the sympathetic ganglion, part of the sympathetic chain ganglia. Okay? on the longitudinal view, that would be one of these ganglia here. Okay, one of these ganglia. So it's getting into that sympathetic chain ganglion, and the way it's getting into it is by traveling through this little branch that you see right here, known as the white ramus communicans. Ramus means branch, communicans means communicating, so it's a communicating branch that communicates between the spinal nerve and the sympathetic ganglion. It's called the white ramus communicans because it looks white. And the reason it looks white is because these preganglionic fibers are heavily covered with myelin. And with all that myelin is white, and so the fibers look white, so the ramus looks white. Okay, so the preganglionic fiber, in this case, gets into the ganglion. Remember, living in a ganglion are cell bodies. And these are the postganglionic sympathetic cell bodies. So it synapses on that cell body. That second neuron, that postganglionic neuron, its job is to get to an end organ to innervate it. So how does it get to an end organ? It needs a way of traveling to the end organ. The end organ is going to be, for the most part, found out in the body wall, in the skin, like sweat glands on the skin, or smooth muscle in the skin, or smooth muscle in the walls of blood vessels. So it has to get to those things. And the way it's going to get there is by traveling along with branches of the spinal nerve, anterior ramus branches or posterior ramus branches. And so what these postganglionic fibers do is they leave the ganglion, the sympathetic ganglion, to get back to the spinal nerve and then travel with the spinal nerve. Now remember, in that spinal nerve we already have other kinds of nerve fibers, the somatic nerve fibers that we talked about before that are going out to innervate skeletal muscles. They're part of that spinal nerve already. And there are sensory fibers in there coming back to bring sensory information. So now these fibers are simply joining those and traveling with them to get to wherever they have to go. And when they get there, they innervate a smooth muscle cell, or they innervate glandular epithelium. Okay? This branch that's getting this postganglionic fiber from the ganglion to the spinal nerve is called a gray ramus communicans. Well, we already know what ramus and communicans means, and it's called gray because these are unmyelinated fibers. Postganglionic fibers are unmyelinated, and so the absence of myelin causes these fibers to look gray. So what we therefore can say is that white ramus communicans contains preganglionic sympathetic fibers, gray ramus communicans contains postganglionic sympathetic fibers. Okay? So that's easy. Okay? We've now established a very simple way to get sympathetic fibers to the parts of the body wall that are receiving their innervation from spinal nerve T1 to L2. But remember, we said we have to get sympathetics all over the body. We have to get them above T1 and below L2 also. So how are we going to do that? Well, if we come back to this picture, on this illustration, these three lines, which are just examples, don't take this too literally, these three lines are representatives of what we were just talking about. A preganglionic getting to a sympathetic ganglion, a postganglionic getting on out to, that asterisk means, to smooth muscle and sweat glands in the body wall. Okay? But that's happening at all levels, not just at these three levels. But now the question is, how do we get to higher levels above T1? And how do we get to lower levels below L2? And what we can see here is that some of these fibers that are coming from T1, some of them do pretty much the same thing that we just talked about, but others enter the sympathetic ganglion, but they don't synapse there. Instead, they turn upward and they ascend and go to ganglia that are even further up, above T1, ganglia up in the neck, the cervical sympathetic ganglia, part of the sympathetic chain. But remember, we don't have preganglionics in this part of the spinal cord, so we can't get preganglionics from here to there. What we have to do is take the preganglionics from here and bring them up there. So we have preganglionic fibers that ascend through the sympathetic chain to get to the sympathetic ganglia at cervical levels. Once they get to one of the sympathetic ganglia, this is just showing one example, but there are usually three cervical sympathetic ganglia. It goes to one of those three, and it synapses in that ganglion. And then the postganglionic can do the same thing that we talked about down here. They can join the spinal nerve through gray rami and travel with those spinal nerves and get to the skin of this part of the body, right? Not a problem. And then we can say exactly the same thing down for the regions below L2. We have preganglionic fibers, same idea. They go into the sympathetic ganglion through a white ramus, but they don't synapse there. Instead, they descend to one of the lower ganglia, L3 or L4 or L5 or S1 or S2, any of those ganglia lower down. When they get there, they synapse on a postganglionic that lives there. And then the postganglionic goes through a gray ramus, joins the spinal nerve at that level, and goes to the skin there. Okay? So now, using those two mechanisms, we have now established a way to get to the body wall of any part of the body where a spinal nerve goes there, right? No matter which spinal nerve it is, even if it's above T1 or below L2. Now, there's still a couple of more issues we have to deal with. Firstly, not all skin of the body receives spinal nerve innervation. There's a significant part of the body that doesn't get spinal nerve innervation, but rather gets cranial nerve innervation, specifically the skin of the front of the head. All of this region does not get any spinal nerve innervation. It gets cranial nerve innervation. And cranial nerves don't carry sympathetics. Remember, we said parasympathetics travel with cranial nerves. So how are we going to get sympathetic innervation to this part of the body? And that's what's being illustrated on this diagram. We have a preganglionic coming from T1, usually, right? Ascending through the sympathetic chain, synapsing in the superior cervical ganglion, the highest of the ganglion. In other words, it's going as high as it can go, the highest cervical ganglion. It can't get up into the head because the ganglion don't go that high. Synapses there. The postganglionic, since it can't use a spinal nerve to get here, because there are no spinal nerves to go here, it has to find a different way of getting here. And so what those postganglionics do is they jump onto and travel along with blood vessels. They become enmeshed in the connective tissue that surrounds the blood vessels going to the head, specifically the carotid arteries and branches of the carotid. Okay? And so these postganglionic nerve fibers, which travel with the carotid system of arteries, is called the pericarotid plexus. The pericarotid plexus. And it's by way of that mechanism that we get sympathetic innervation to the sweat glands and smooth muscle and so forth in the front of the head. Okay? Now, before we go on to the next point, this is an important clinical issue. That means that if I were to have any interruption in my sympathetic pathway between here and here, in other words, any damage to this, to this, to this, to this, to this, to this, anywhere along there, I would lose the sympathetic innervation to my head, to the front of my head. And you would have certain results of that loss of sympathetic innervation that become easily observable. Specifically, you would get a loss of sweating on that side of the head, since the sweat glands are innervated by sympathetics. The smooth muscle of the iris of your eye that dilates your pupil is innervated by sympathetics. So with the loss of the dilator smooth muscle, the constrictors would cause your pupils to constrict, the pupil on that side to constrict. And there is smooth muscle involved in keeping your eyelid elevated. And with the loss of and that's sympathetically innervated, so with the loss of sympathetic innervation, that muscle wouldn't be working, would be paralyzed, so your eyelid would droop. So you would have a drooping of your eyelid, you'd have a constriction of your pupil, you'd have a loss of sweating on that side of your head. And those three findings in combination are called Horner's syndrome. So Horner's syndrome means that you have a loss of sympathetic innervation to that side of the head. But that finding in and of itself does not tell you where the lesion is. It just tells you that you have a lesion. somewhere between here and there. But you would get a Horner's syndrome if you lesioned it here, or lesioned it here, or lesioned it here, or here, or here, or here. All of those would give you a Horner's syndrome. So when reading a question about a patient with Horner's syndrome, or the question may not say Horner's syndrome, it may describe the findings that you would put together to know that it is a Horner's syndrome. If the question then goes on to ask you where the lesion is, realize that the Horner's syndrome itself will not tell you where the lesion is. It will simply tell you that there is a lesion. You're going to have to keep reading the question. There will be something else in that question that will give you other information that will help you localize where the lesion is. So Horner's syndrome doesn't tell you where the lesion is. It just tells you that there is a lesion somewhere along the sympathetic pathway to the head. Okay? Now, we've now dealt with some preganglionic sympathetics that leave the spinal cord, go to the sympathetic ganglion, and synapse there. We've dealt with others that leave the spinal cord, go to the sympathetic chain, and rather than synapsing there, ascend the chain or descend the chain and synapse at other levels of the sympathetic chain. But now we have to deal with yet one other kind of sympathetics, preganglionic sympathetics, and these are being illustrated on this diagram, and this part of the diagram by example, and on this part of the diagram. And this is showing you preganglionic fibers that leave the spinal cord, go to the sympathetic chain, and not only don't they synapse at that level, they don't synapse anywhere in the sympathetic chain. They don't ascend or descend. They just keep right on going and continue on out into the peripheral nervous system, but they're still preganglionics. Okay? Now we know that preganglionics don't innervate end organs, right, except for the adrenal medulla. So these preganglionics, which haven't synapsed in the sympathetic chain, they need to synapse someplace. And so we will find another group of ganglia, another family of ganglia that are found out here in the abdomen. And they're found on the front wall of the front surface of the abdominal aorta. They're called pre-aortic ganglia or pre-vertebral ganglia. Those can be used interchangeably. And these preganglionic fibers synapse in those pre-aortic ganglia, one of those pre-aortic ganglia. These fibers that are doing what I just described are called sympathetic splanchnic nerves, sympathetic splanchnics. They are preganglionic fibers that have passed through the sympathetic chain without synapsing and continue on out to synapse in pre-aortic ganglia. If they're coming from thoracic levels, we call them thoracic splanchnics. If they're coming from lumbar levels, we call them lumbar splanchnics. Okay? But they are all the same in the sense that they are going to be going to one or another of the pre-aortic ganglia. Once they get to that pre-aortic ganglion, they synapse there. There are cell body, post-ganglionic sympathetic cell bodies that are living in those ganglia. They synapse on them. And then the post-ganglionics send their axons out to the smooth muscle and glands of the organs in the abdomen. Okay? How do you get from these ganglia to these organs in the abdomen? And the answer is blood vessels. The same mechanism that we used up here, we're using here. Remember that these ganglia are sitting right on the front surface of the aorta. Well, there are branches leaving the aorta at each of these levels, the celiac trunk, the superior mesenteric artery, and so forth. So these postganglionic fibers are traveling with those branches of the aorta. And since all of the organs in the abdomen have a blood supply, that means we must have a pathway to get to any organ we want to get to, and that's the pathway that these sympathetics use. Okay? So that's a fairly rapid summary of how we deal with sympathetic innervation. Now, what about parasympathetic innervation? Let's go back to figure 319. We need to deal with parasympathetic innervation in two different categories. First, we already said that parasympathetics come from cranial levels and come from sacral levels. What I'd like to do is divide the parasympathetics up into two categories, but not quite that way. What I'd like to do is divide them up, put cranial nerves 3, 7, and 9 into one category. In other words, everything above there into one category, and then everything below there, cranial nerve 10 plus the sacral nerves, into another category. And let's deal with the second category first. Cranial nerve 10, which is the vagus, and then the S2, 3, and 4 spinal nerve levels. If we look at S2, 3, and 4, what we find is that the preganglionics leave the spinal cord. Remember, we said one of the characteristics that we typically find in parasympathetics is they have long preganglionics that go all the way to the walls of the organs that are going to be innervated, because the postganglionics are in those walls. And that's what we see happening here. These preganglionics from S2, 3, and 4 are going all the way to the walls of the organs found in the pelvis, things like the rectum and the sigmoid colon, bladder, and stuff like that. And they're synapsing on the postganglionic parasympathetics that live in those walls, and then those postganglionics are innervating the smooth muscle and glands and so forth in those walls. Okay? Very simple. The vagus nerve does fundamentally the same thing. Long preganglionics going right to the walls of organs, innervating those organs. The vagus nerve does basically the same thing as the sacral nerves do. The difference is where they do that. The vagus nerve takes care of the organs that are in the chest and most of the organs that are in the abdomen, whereas the sacral nerves take care of organs primarily in the pelvis. Okay? So all of the organs in the chest, the heart, the lungs, the airway, as well as most of the GI tract, the esophagus, stomach, duodenum, small intestine, and a good bit of the large intestine, the liver, the pancreas, all of that gets its parasympathetic innervation from the vagus, and it does it in the same way. Long preganglionics, synapsing in terminal ganglia in the walls of the organs. Notice that even though the vagus nerve is arising from the brainstem in the head, none of the parasympathetics from the vagus innervate things in the head. It's innervating things in the thorax and abdomen. Now, in contrast, if we look at cranial nerves 3, 7, and 9, we see a different story. The first thing that's different is that these preganglionics are going to be involved in a pathway to innervate structures in the head. So 3, 7, and 9 takes care of parasympathetic innervation to the head. 10 does not. The other thing that's different is that these parasympathetics do not go to terminal ganglia found in the walls of organs, but rather they go to ganglia found in the head, and you see those ganglia listed here: ciliary ganglion, submandibular ganglion, pterygopalatine ganglion, and otic ganglion. Those are 4 parasympathetic ganglia found in various places in the head, and they synapse in those ganglia. And then the postganglionics go from those ganglia to their respective end organs, which are largely either smooth muscles or salivary glands or glands of the mucosa of the pharynx and derivatives of the pharynx. Okay, so mucosal glands. So they're either going to mucosal glands or salivary glands or smooth muscle in the head. Okay. Okay, so that's the story of the parasympathetic nervous system. Now, the last thing we can say about the autonomic nervous system is that we started off by saying sympathetics go everywhere in the body. Parasympathetics don't go everywhere in the body. Parasympathetics are more restricted in where they go. Parasympathetics don't go to the body wall. They don't innervate sweat glands in the skin. They don't innervate smooth muscle in the skin. They don't go to body wall structures. They go to visceral organs. And visceral organs are found in the chest, in the abdomen, in the pelvis, and in a few cases in the head. So parasympathetics only innervate structures in the head, thorax, abdomen, and pelvis. They don't go to any of the limbs. Okay? So that's one difference. Sympathetics distribute everywhere. Parasympathetics do not go everywhere. They're more restricted. So that is going to tell us that since sympathetics go everywhere and parasympathetics go some places, overlapping where sympathetics go, we're going to have a lot of things that are innervated by both sympathetics and parasympathetics, but we're going to have other things that are innervated only by sympathetics. So things like sweat glands, only sympathetic innervation. Vascular smooth muscle in the skin, only sympathetic innervation. Erector pili muscle in the skin, only sympathetic innervation. In contrast, things like the GI tract, the heart, the lungs, and other visceral organs get both sympathetic and parasympathetic innervation. And typically, not always, but typically, those organs that receive both sympathetic and parasympathetic innervation, the result of stimulation of those nerves, sympathetic versus parasympathetic, typically has opposite effects. So, as an example, sympathetic stimulation to the heart increases heart rate, parasympathetic decreases heart rate. Sympathetic innervation to the iris dilates the pupil, parasympathetic constricts the pupil. Okay? Sympathetic innervation to the airway dilates the airway, parasympathetic constricts the airway. Okay? Parasympathetic innervation to the gut increases gut motility. Sympathetic innervation to the gut decreases gut motility. So when we sort of put all of those many different things together and sort of look at the big picture instead of doing this organ by organ, what we see is the kinds of things that an organism does in an emergency situation are those things that are sympathetically innervated in general. And if you think about, you find yourself, you're walking someplace and all of a sudden you find somebody's chasing you. Think about what happens. Your heart rate increases, you sweat, your pupils dilate, right? Your airway increases in size so you can get more oxygen, so you can have more ability to run faster, okay? Those are all sympathetic events. On the other hand, when you are doing the kinds of things to restore your energy when you're resting, increases gut motility, so more digestion, liver secretion, pancreatic secretion, gastric secretion, all of those digestive functions in order to restore the energy you've used up during that previous emergency. Those tend to be parasympathetically innervated. Okay, so if you think about these in sort of a big picture way, you can sort of categorize what is sympathetically innervated and what is parasympathetically innervated. That, it's not going to be perfect, but that will cover about 90% of the autonomic innervation. Okay, we're going to move on now to the thorax. And I want to start off with the thoracic wall just briefly. And the first clinically important thing to pay attention to on the thoracic wall, of course, is the breast. And I want to use this illustration to do that. A couple of important things for you to be aware of with regard to the breast. Firstly, the breast is entirely found within the superficial fascia. It's found between the skin and the deep fascia. Okay? All of the breast. Now, the breast contains both glandular tissue with ducts, seen here, and then all of the spaces between the glandular tissue and ducts is filled in with fat. Much of the fat has been removed from this illustration. But all of that is found between the overlying skin and the underlying deep fascia covering the muscle. And it's because of the fact that it is superficial to the deep fascia, in the superficial fascia, that it's mobile, that it can move on the surface of the body. Now, the overlying skin is attached to the underlying deep fascia by bands of connective tissue called the suspensory ligaments of the breast, also called Cooper's ligaments. Okay? So the overlying skin is connected to the underlying deep fascia by these suspensory ligaments. The reason that becomes important is that when when a mass develops in the breast, the presence of that mass taking up space is going to distort these bands of connective tissues, push them. And that distortion of the bands of connective tissue will tend to pull in on the overlying skin. And so the dimpling that is sometimes seen in advanced breast cancer is a result of a stretching or a distortion of these suspensory ligaments by the expansion of the tumor in the breast. Okay? Now, the glandular tissue itself, which of course secretes milk, that ends up being carried through lactiferous ducts. The lactiferous ducts, of course, open on the nipple. Probably the one most important thing to have in your mind about the breast is lymphatic drainage, because breast cancers tend to spread by way of lymphatics. And so what you need to remember is that the lateral half of the breast, as well as the nipple and the areola of the breast, all of the lymphatics from there drain laterally toward the lymph nodes that are found in the axilla. And that's why when a patient has a primary tumor in the breast, axillary lymph nodes are taken and looked at to see if there's been metastasis to those lymph nodes. On the other hand, the medial half of the breast, although it may have a little bit of drainage toward the axilla, most of that drainage is toward the midline to a chain of lymph nodes found just behind the costal cartilages, known as the parasternal lymph nodes or the internal mammary lymph nodes. Okay, so the medial half of the breast tends to drain medially. The lateral half of the breast tends to drain laterally toward the axilla. Of particular importance is the fact that some of these lymphatic channels that drain medially actually cross the midline and drain to the lymph nodes, parasternal or internal mammary lymph nodes on the other side, and communicate with lymphatic drainage from the other breast. And it's that communication across the midline in lymphatic drainage which accounts for the metastasis of breast cancer from one breast to the other. And it's because the medial half of the breast tends to drain toward the midline, so that's where you would tend to get metastasis across the midline, whereas primary tumors arising in the lateral portion of the breast will tend not to do that because they will drain toward the axilla. Okay? On this diagram, we can see over here, because a couple of the costal cartilages have been removed, we can see the internal thoracic or internal mammary artery and veins, and it's along that same region where those internal mammary lymph nodes or parasternal lymph nodes are found. Okay? All right, now, in terms of landmarks on the chest wall itself, let's take a look at this diagram. And what we can see is that the chest wall, the bony chest wall, is made up of a sternum, some ribs, and a vertebral column. Okay? The sternum has the sternum has three portions, two of which I want to point out to you. The upper portion is called the manubrium. This portion, the largest portion, is called the body. And we have a landmark at the junction of those two portions called the manubrio-sternal junction, or the sternal angle, because it's a palpable landmark. These two portions of the sternum meet at an angle, and so you can feel that landmark. That's the manubrio-sternal junction. That's going to be an important landmark for us, because we will find that the second rib attaches to the sternum right at that manubrio-sternal junction. And that's important because there are going to be times when we're going to have to be able to count ribs reliably and know which rib we're palpating. For instance, if you're going to be introducing an instrument into a patient's chest and you want to specifically go through a particular intercostal space because of where you want to go, you need to know which rib is which. And so if you start off by palpating the sternal angle, knowing that the second rib is attaching at the sternal angle, you can then count down from there and know that you'll have an accurate location. We also will know that this sternal angle is at the level of the fourth thoracic vertebra. The sternal angle is at the level of T4, and that's an important thing to keep in mind. And later on, when we start to look at structures in the chest, we're going to be dividing those structures according to whether they're above T4 or below T4. And so the manubriosternal junction becomes a useful landmark for us for that purpose, knowing that the manubrium will be in front of the structures that are above T4, whereas the body of the sternum will be in front of the structures that are below T4. And that's going to be helpful to us also. The last point I want to make about the chest wall is that between the ribs, there's going to be soft tissue, mostly muscle, some connective tissue. And that's not really important. But we are also going to have blood vessels running through each of the intercostal spaces. Intercostal arteries and veins, as well as nerves, intercostal nerves. Those nerves and those blood vessels are going to be supplying the entire chest wall, the entire thickness of the chest wall. That means the skin, starting on the outside, the skin, going right on through, including the muscles of the chest wall, the bone of the chest wall, the ribs, get their blood supply and their nerve supply from these intercostal structures, neurovascular structures, and the inner lining of the chest wall, which is the parietal pleura, gets its blood supply and nerve supply from the intercostal arteries, veins, nerves. Okay? So remember that parietal pleura is part of the chest wall and therefore gets innervated and gets its blood supply the same way as everything else in the chest wall does. Okay? Those intercostal blood vessels, the intercostal arteries, arise posteriorly from the aorta mostly, and anteriorly they arise from the internal thoracic or internal mammary arteries. That means that the intercostal arteries are important collateral pathways between two major longitudinal arterial channels in the chest, the aorta posteriorly and the internal thoracic anteriorly. And therefore those intercostal arteries can be used and are used as collateral channels to bypass obstructions in the vasculature of the chest. And it's for that reason that one of the findings associated with coarctation of the aorta, which is a congenital defect, this narrowing of the aorta causes an increased blood flow through the intercostal arteries. The increase of blood flow through the intercostal arteries causes those arteries to get larger, to grow. The growth of those arteries, which are found right along the lower border of the ribs, causes the ribs to thin out to make room for these growing arteries, which therefore results in what's known as costal notching. A costal notching, a thinning out of the lower border of the rib, is pretty much diagnostic of coarctation of the aorta. But the reason that it's associated with it is that the coarctation of the aorta results in collateral flow through the intercostals, which results in a growth of the intercostals, which results in a thinning of the ribs. And so where the rib is thinning is where the artery is found, which is the lower border of the rib. That's also where the nerve and the veins are found, along the lower border of the rib. So that means that if you want to pass an instrument through an intercostal space, so you want to insert a chest tube, and you don't want to risk damage to an intercostal nerve or artery or vein, when you pass it through an intercostal space, you stay away from the lower border of the rib. You stay in the lower part of the intercostal space, near the upper border of the next rib. So by staying in the lower portion of the intercostal space, as you pass an instrument through the intercostal space, you'll avoid the intercostal neurovascular bundle. On the other hand, if you want to inject the local anesthetic to block conduction in an intercostal nerve, Let's say a patient has a fractured rib. Remember, intercostal nerves innervate the ribs. And if you want to block conduction in that intercostal nerve, then you would inject the local anesthetic in the upper portion of the intercostal space, because that's where the nerve is. So what I'm saying is you could be asked questions about how to avoid the intercostal neurovascular bundle or how to aim for the intercostal neurovascular bundle. In either event, I mean, they sound like two different kinds of questions, but both questions are really just asking you where in the intercostal space is the intercostal neurovascular bundle found, and the answer is in the upper border of the space along the lower edge of the ribs. Okay, we'll take a break, and when we resume, we'll get on to the interior of the chest cavity and start to talk about the lungs, and then go on to the heart after that. Let's take a break.